Today, we're diving into distributive shock, one of the major categories of shock. Unlike hypovolemic or cardiogenic shock, distributive shock isn't about not having enough fluid in the body or the heart being too weak to pump. Instead, the problem lies in the blood vessels themselves. What is distributive shock? Distributive shock happens when blood pools in the peripheral vessels because the vessels lose their normal tone. This abnormal vasodilation causes what we call a relative hypovolemia. Even though the total fluid volume may be normal, too much blood is stuck in the periphery and not enough is returning to the heart. With less venous return, the stroke volume and cardiac output drop. That means blood pressure falls and tissue perfusion suffers. There are three main types of distributive shock. 1. Septic shock, caused by infection and overwhelming inflammation. 2. Neurogenic shock, caused by a loss of sympathetic nervous system tone, often from spinal cord injury. 3. Anaphylactic shock, caused by a severe allergic reaction with massive histamine release. Let's break them down. Septic shock. Septic shock is the most common form of distributive shock. It develops as a complication of widespread infection, where the body's immune system goes into overdrive. Pathophysiology. When microorganisms invade tissues, the immune response releases cytokines and other chemical mediators. This sets off a cascade of inflammation known as the systemic inflammatory response syndrome, or SIRS. Increased capillary permeability allows fluid to leak out of the vessels, while vasodilation lowers systemic vascular resistance. Blood can no longer be distributed effectively, and tissues become starved of oxygen. At first, patients may present with what we call warm shock: fever, flushed skin, bounding pulses, and tachycardia. The respiratory rate rises, and urine output may begin to fall. As sepsis progresses, perfusion worsens. Blood pressure fails to respond to fluids. The skin becomes cool and mottled, urine output stops, and multiple organ dysfunction develops. Management. Identify and treat infection quickly. Cultures of blood, urine, sputum, and wounds should be obtained before antibiotics are started. Antibiotics must be given within the first hour of recognition. Fluid resuscitation, at least 30 milliliters per kilogram of crystalloid solution over 30 minutes. If hypotension persists, start vasopressors such as norepinephrine to maintain a mean arterial pressure of at least 65 millimeters of mercury. Monitor lactate levels, urine output, and mental status to gauge perfusion. Sepsis bundles, the Surviving Sepsis Campaign and CMS core measures recommend. Measure lactate. Obtain blood cultures before antibiotics. Give broad-spectrum antibiotics. Administer fluids rapidly. Use vasopressors if blood pressure remains low. Nursing management. Use strict infection control practices like hand hygiene and a septic technique. Monitor all invasive lines and catheters for infection. Recognize subtle early signs in high-risk patients, especially the elderly. Confusion, agitation, and rapid breathing may be the first clues. Use assessment tools like the SOFA score, qSOFA, or modified early warning score to track risk and detect deterioration early. Neurogenic shock. Neurogenic shock results from the loss of sympathetic tone, most commonly after a spinal cord injury. Instead of the expected vasoconstriction during stress, the body defaults to parasympathetic stimulation. The blood vessels dilate, blood pressure falls, and bradycardia occurs. This is different from other shock types, which usually involve tachycardia. Clinical features: hypotension with bradycardia, warm, dry skin instead of cool, clammy skin, signs of inadequate tissue perfusion. Management: stabilize the spinal injury if present. Elevate the head of the bed at least 30 degrees during spinal or epidural anesthesia to prevent spread of the anesthetic. Support blood pressure with fluids and vasoactive medications as ordered. Prevent complications such as deep vein thrombosis, since pooling of blood in dilated vessels increases the risk. Use compression devices and anticoagulants when indicated. Anaphylactic shock. Anaphylactic shock is a severe allergic reaction triggered by foods, medications, insect stings, or latex. It's mediated by IgE antibodies that activate mast cells to release histamine and other mediators. The result is widespread vasodilation, capillary leak, bronchospasm, and cardiovascular collapse. Symptoms can appear within minutes: headache, lightheadedness, nausea, or abdominal pain, pruritus, flushing, and diffuse erythema, respiratory distress from laryngeal edema or bronchospasm, hypotension, arrhythmias, and a sense of impending doom. Management: remove the antigen, for example, stop the antibiotic infusion. Give intramuscular epinephrine immediately. Administer IV diphenhydramine to block histamine. Provide nebulized albuterol for bronchospasm. Support airway and breathing with oxygen or intubation if needed. Provide rapid IV fluids to counteract the massive capillary leak. Be ready to initiate CPR if cardiac arrest occurs. Nursing role: prevention is key. Always assess patients for allergies before giving medications, blood products, or contrast dye. Educate patients and families to carry epinephrine auto-injectors if they have known severe allergies. Stay vigilant after giving new medications, especially antibiotics, ACE inhibitors, beta blockers, aspirin, or NSAIDs. Provide emotional support and explanations during and after the event. Distributive shock includes septic, neurogenic, and anaphylactic shock. All three involve peripheral vasodilation and relative hypovolemia. Septic shock is the most common and deadliest, requiring immediate antibiotics, fluids, and vasopressors. Neurogenic shock is marked by bradycardia and warm skin, unlike other shock types. Anaphylactic shock demands epinephrine without delay. Early recognition, rapid interventions, and compassionate nursing care are what make the difference between recovery and decline.